What I wanted to cover was the following. I am, as you've heard, a respirologist, a lung specialist. I'd like to introduce you to two patients, and we'll look at their care side by side, Mr. Weir, Mr. Smith, and you're going to discover why lung specialists rather envy the heart specialists, the cardiologists. There's this other issue. I spent a lot of time talking about it when I talk to doctors about COPD, measuring what they're meant to be treating. And there seems to be this notion out there that real doctors don't have to use this fancy, nonsensical measurement stuff called spirometry. We'll talk a bit about that. I want to talk about treatment, but I must tell you that doctors do get preoccupied with their prescription pads. So I'm going to choose one study, one example, but the important message will not be which treatment, what the brand name is, or how much of it you take, but some of the impact of available treatments today. It is getting better and better all the time. And then a question I think most of you had wanted to ask, what can I do? And quite obviously everybody in this auditorium has taken the first step, or the first, second, third, and fourth steps, which is to become very effective partners in their own care. But I want to put some specifics to that. And I'll end not with the traditional summary, my flat-out statements of the way things are and aren't, but simply some questions that I think everyone in this room must ask about their own care. So without further ado, let me introduce you to patients. Mr. Weir, Mr. Smith. These are patients the way doctors might meet them. Patients the way your family doctor might meet them. Mr. Weir's a man in his late 50s. He's got a job, and he goes to his family doctor 2 weeks after a hospitalization. There's been a big, big event in his life. He's had an uncomplicated, no problems with it, acute MI, stands for myocardial infarction, heart attack. And that gets everybody's attention. Heart attacks are important things. So, he's been overweight. He's been a smoker up to his hospitalization. What's his family doctor going to do? That's Mr. Weir. Let me introduce you to somebody else, Mr. Smith. Same age. Busy working at his career up until a hospitalization a couple of weeks ago. He was in hospital for an uncomplicated flare-up exacerbation of COPD. He'd been overweight, and yeah, up till he'd been hospitalized, he'd been a smoker. Same sort of story. Hearts, lungs. What's the family doctor going to do? And when I talk to doctors, I put up this little table, and let me walk through it with you. The family doctor is going to want to assess the problem, prescribe some medicines for the problem. Doctors these days get very technical about analyzing research, and they want to know if they can prevent problems, and if so, how many patients do they have to treat with a certain medicine or strategy to prevent something from happening, like another heart attack. That's called NNT, numbers needed to treat, a measurement of the strength of one's effect. Lifestyle. All right, these two fellas have let their weight creep up. They've been smokers. What are we going to do about that? Self-management plans. I'll give you an example in a moment. And, sorry, doctors need to talk about the consequences of these problems, heart and lung problems. What's the one-year mortality? What's the likelihood that something really bad is going to happen over the coming year to either one of these folks? So let's start filling in the blanks. And I'll tell you, your family doctors will nail this middle column for Mr. Weir. They will say, okay, he's going to have an exercise stress test. Some of you in the room may have had it if there's been any concern about your heart health. And they'll have an echocardiogram, a measurement of the heart's pumping capacity. In fact, these things are so routine after a heart attack, they may well have happened before somebody left the hospital. The medicines, I will guarantee you that unless there's an allergy concern, every single one of the heart patients leaving any hospital in North America is going to be on the 4 medicines there. We're talking about aspirin, something called a beta blocker, something called a statin, like that famous one, Lipitor, and an ACE inhibitor, a fancy former blood pressure medicine that we now realize has all sorts of helpful properties to blood vessels. Numbers needed to treat, we can say that giving a statin reduces, we can reduce the likelihood of a heart attack by treating 33 people with a statin. We know precisely what we're doing. We know that Mr. Weir's going to have to quit smoking, and he might get some help with that. He's going to get some help with weight loss, and he's probably going to get to a rehab clinic. There seem to be lots of cardiac rehab clinics out there where people can go and jog on treadmills. Self-management plan, he's going to get it very carefully explained, probably before he walks out the hospital door, and it will be reiterated by his family doctor. You take your nitroglycerin tablet if you get chest pain, or you take your nitroglycerin spray, and you know what? You could take it a second time if that pain's not going away, but if that pain lasts longer than a few minutes, and 2 sprays or 2 tablets doesn't do the trick, get yourself to the emergency room. Very clear instructions. And the 1-year mortality, well, way back in the dark ages when I started medicine, it might have been 20 or 30% over the next year. But these days, it's pretty low, under 5%. The docs treating hearts are doing a really good job because the family doctors know what to do and the care is comprehensive. How about Mr. Smith? I just want to point out, Mr. Smith is likely to go back to the family doctor. He's not likely to get to a specialist, and there's not likely to be a whole lot of fancy measurement going on because, well, it's just a flare-up of cough and phlegm, right? Well, if he had been in the intensive care unit, his likelihood of having a bad outcome in the next year is 20 to 24%. Just being hospitalized with COPD, the risk of losing your life to it over the next year, about 20 to 25%. It's a pretty common figure, the sort of numbers we used to have for heart disease 20 years ago. And we could go on with examples of treatment failures. In other words, that COPD exacerbation isn't just phlegm. It means something very seriously wrong is involving the lungs, and somebody's at very serious risk, just as serious as the heart. We've lately talked about calling these things not COPD exacerbations, that's too many syllables, but lung attacks. Maybe people would get the idea then. So, in this day and age, what's likely to happen with poor Mr. Smith? Well, if he's lucky and his family doctor's attentive, he might get a listened to with a stethoscope, he might get a chest x-ray, but probably not much fancier a measurement than those two. He might get, and those are some drug names up there, the generic names, some sprays. Doctors just say, puffers, take your puffers. Doctors aren't too clever about how many patients they need to treat to prevent events. They don't really think about preventing events. They do know about smoking cessation, but they don't get their patients into rehab very much. Self-management plans, well, not so much. And we talked about it. The risk in the next year is pretty high. So what are we going to do about it? And I want to talk about some of the specifics and some of the strategies that you can employ to make sure that your care for lung disease in the right-hand column starts to look a little bit more like the care in the middle column that's comprehensive. Here's problem number 1. It's an old bugbear of mine, this notion that real doctors who really know their stuff don't have to rely on that fancy technology called spirometry. And I'll show you what I mean. First of all, when we talk about COPD, chronic obstructive pulmonary disease, what do we mean? Well, these days we refer to an international set of instructions or guidelines for doctors. We call them the GOLD guidelines. And for change, they're pretty straightforward and pretty simple. It says COPD is the presence of airflow obstruction. The air doesn't flow as well as it should. It results from chronic exposure to a noxious substance. I might say, why that gobbledygook? Why don't they just say smoking? Well, yeah, smoking in our country is usually the cause, but in fact, in many other countries, it may be the smoke of cooking fires in a poorly ventilated hut. So there are different exposures that lead to COPD. And then finally, the thing that makes COPD different from asthma, which is also a disease of airflow obstruction, when we treat it, it's not completely reversible. We can't make all the changes disappear. Many or most of those changes, the obstruction, are permanent. So you'd look at that definition, that's what doctors are supposed to be working with, and you'd say, well, okay, airflow obstruction, so they probably measure airflow, right? That's what they should be doing. Everybody in this room, I suspect, has had a spirometry. There's a picture of smiling patient, helpful technician, 5 minutes, 2 or 3 efforts, and a good reproducible result. That's the theory. But let me show you the practice. Many years ago, more years than I care to remember, a colleague and I did a survey in Canada. We asked 80 primary care doctors, family doctors, just hypothetically, how would they approach the following patient? We said, it's a man about 52. He's been a smoker